Let's get started. Let's start off with a case. Let's say a 38-year-old man is brought to the emergency department by ambulance after a motor vehicle accident. He is pale and hypotensive. He is immediately taken to surgery, during which he is transfused with 4 units of packed red blood cells. The surgery is otherwise uncomplicated, and the patient is doing well after surgery and in no apparent distress. 4 hours later, he suddenly becomes short of breath, with oxygen saturation dropping to 82% on room air, respiratory rate is 29 per minute, and pulse increases to 142 per minute. A chest x-ray shows diffuse infiltrates. Let's keep this case in mind as we go through the lecture. So, our learning objectives are to differentiate the various blood transfusion reactions based on their pathogenesis, timing, and clinical presentation, and to recognize the different immunological components in donor blood and in host blood in blood transfusion reactions. So the blood transfusion reactions we're going to be discussing are allergic or anaphylactic reactions, acute hemolytic transfusion reactions, febrile non-hemolytic transfusion reactions, transfusion-related acute lung injuries, and delayed hemolytic transfusion reactions. Well, first, let's discuss the allergic or anaphylactic reactions. When you think of anaphylactic reactions, what type of hypersensitivity reaction comes to mind? Yep, you're right if you're saying type 1. This type 1 hypersensitivity reaction is against the plasma proteins in the transfused blood. For example, individuals with IgA deficiency who have anti-IgA antibodies should receive blood products that do not have IgA, or they could have an allergic reaction. When we think of the timing of anaphylaxis, does it occur quickly or slowly? Yep, you're right if you're saying really quickly. It can occur within minutes to really not more than 2 to 3 hours. This happens due to the release of preformed inflammatory mediators in degranulating mast cells. Now, when you think of someone who's allergic to something, what do you think of? Maybe itching or hives or trouble breathing? So the clinical presentation of these reactions would be exactly that: urticaria, pruritus, wheezing, hypotension, possibly even respiratory arrest or shock. The specific components that make this reaction would be donor plasma proteins like IgA, the dimer we see here, and the host mast cells that we see here. Next, we have acute hemolytic transfusion reactions. These are type 2 hypersensitivity reactions that typically cause intravascular hemolysis, or the breaking of red blood cells inside vessels due to an ABO blood group incompatibility. So, in the donor blood, there will be red blood cells with antigens to A or B, like in this image, and the host or recipient of the transfusion will have anti-A or anti-B IgG and IgM, like in this image. Can you remember which one is the pentamer on the right? Yep, it's IgM. So you can imagine this reaction is going to happen fast. It's known as an acute transfusion reaction after all. It can occur during the transfusion or within 24 hours after, because the antibodies are already preformed. Patients can present with fever, hypotension, tachypnea, tachycardia, flank pain, hemoglobinuria, and jaundice. Next, we have febrile non-hemolytic transfusion reactions. Let's take a look at this image, where we are looking at a white blood cell in donor blood that is releasing a preformed cytokine. So when blood gets donated, these cytokines can accumulate during the storage of blood products. We can prevent these kinds of transfusion reactions by leukoreduction of blood products, which is exactly what it sounds like. We are reducing or filtering out leukocytes from whole blood before transfusion. This occurs within 1 to 6 hours of the transfusion, again, relatively quickly, because the cytokines are preformed. Patients can present with fever, headache, chills, and flushing. This type of blood transfusion reaction is more common in children. Next, let's talk about transfusion-related lung injury. Its pathogenesis involves a two-hit mechanism. First, neutrophils are sequestered and primed in the pulmonary vasculature because of a recipient's risk factors. Then, the neutrophils are activated by a product, like anti-leukocyte antibodies, in the transfused blood, and they release inflammatory mediators. These mediators lead to an increased capillary permeability, which leads to pulmonary edema. So let's look at this image, where a person has neutrophils in their lung vasculature. And when they get a blood transfusion, donor blood has IgG antibodies against leukocytes, which activates those neutrophils and leads to acute lung injury. This can happen within minutes or up to 6 hours after a blood transfusion. Patients will present with respiratory distress and non-cardiogenic pulmonary edema. Finally, let's talk about delayed hemolytic transfusion reactions. These are anamnestic responses, which means a rapid and increased response to something that previously was encountered before. So the donor has red blood cells with foreign antigens like these, and the host already has IgG. So because of this, there is typically an extravascular hemolysis of red blood cells. Now, all of the transfusion reactions we have discussed so far have been relatively quick, in the first few hours, or at least within the first 24 hours. This one is delayed and has an onset over 24 hours after transfusion. It usually presents within 1 to 2 weeks due to the slow destruction by the reticuloendothelial system. Luckily, this is generally self-limited and clinically silent. If anything, patients may have a mild fever and hyperbilirubinemia from the hemolysis. I know that was a lot, so let's do a quick quiz question. Acute hemolytic transfusion reactions are what type of hypersensitivity reaction? Yep, remember, they're a type 2 hypersensitivity reaction. So, do we remember this case? He had a blood transfusion. He was doing okay. Then 4 hours later, he is in respiratory distress and there are pulmonary infiltrates. Which one of our transfusion reactions could this be? Well, since it sounds very respiratory related, this could certainly be transfusion-associated acute lung injury, if the laboratory findings note that antibodies in the donor blood are against the recipient's granulocytes. So, what's the bottom line? Blood transfusion reactions differ by pathogenesis, timing, and clinical presentation. It's important to know good practices in preventing blood transfusion reactions and how to recognize them, as many occur rapidly and immediate action may be necessary to prevent clinical consequences. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard. Hi everyone, this is our lecture on autoantibodies, so let's get started. Now, I know long tables and lists and charts are overwhelming and they're hard to remember, but I've tried to break it up into small related chunks. Now, the first disorders we're going to talk about are related to the neuromuscular junction. First up is myasthenia gravis. It's the most common neuromuscular junction disorder, and it's characterized by ptosis, weakness, and worsening with muscle use.
Your respiratory muscles get weak, and you can have dyspnea. You can get tired from chewing. So what usually helps us mediate all these movements? What do we need at the neuromuscular junction? You're right if this image came to mind, and you're thinking of cholinergic effects. So when you relate it that way, it kind of makes sense that the problem here is an autoantibody to the postsynaptic acetylcholine receptor. It's an anti-acetylcholine receptor antibody. All right, next we have Lambert-Eaton myasthenic syndrome. It's another neuromuscular junction disease, but it's pretty uncommon. This disease has proximal muscle weakness and some autonomic symptoms, but it improves with muscle use. Now, what's happening here? There are autoantibodies to the presynaptic calcium channel, which are decreasing the release of acetylcholine. All right, this batch of autoantibodies has some sort of relationship with lupus. Systemic lupus erythematosus is a systemic, remitting and relapsing autoimmune disease. Here are the characteristic malar rash and discoid rash you can see in lupus. When you think of the autoantibodies for lupus, the first thing that should come to mind is that nonspecific screening antibody that it's often associated with, and that's the anti-nuclear antibody. Now, more specifically, we can think of anti-dsDNA and anti-Smith. Now, what if we were specifically thinking of lupus that was drug-induced? You're right if you said anti-histone antibodies. You can probably guess what I'm going to ask next. All right, can you name a few drugs that cause drug-induced lupus? Well, here's a helpful mnemonic to start. Lupus makes my hips extremely painful. Now, those letters in red stand for methyl-dopa, minocycline, hydralazine, isoniazid, phenytoin, sulfa drugs, etanercept, and procainamide. Well, what do we have left on this chart? We have the ones associated with antiphospholipid syndrome. What is that? Well, it's an autoimmune disorder based on a history of thrombosis or spontaneous abortion, along with these three autoantibodies. The ones associated with lupus are anticardiolipin and the lupus anticoagulant, and the one specifically for antiphospholipid syndrome is anti-beta-2 glycoprotein 1. Next, let's talk about scleroderma a little bit. Systemic sclerosis is a triad of autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. So, something autoimmune with something vascular and fibrosis. When we talk about sclerosis of the skin, it shows up as puffy skin that looks taut, like someone pulled it in certain places, so there's no wrinkles, like in this image. And you can also see pitting of the fingertips like here. Now, there are two types. The diffuse type is widespread, and it progresses pretty rapidly. This one is associated with anti-SCL70, also known as anti-DNA topoisomerase 1. It's handy that it has SCL in it, so at least it'll remind you of scleroderma. But sometimes I feel as if that makes it more likely for question writers to ask you its other name. Now, limited scleroderma is also known as CREST syndrome. The C is for calcinotus cutis, like you can see here, and anti-centromere antibody. The R is for Raynaud phenomenon, like you can see the color changes in the fingers here. The E is for esophageal dysmotility, the S is for sclerodactyly, and the T is for telangiectasias. But its clinical course is much more benign. Anyway, moving on to polymyositis and dermatomyositis, the specific markers for these are anti-Jo1, or anti-histidyl tRNA synthetase, anti-SRP, or signal recognition particle, and anti-helicase, or anti-MI2. Now, here are some images of the characteristic findings in dermatomyositis, like the Gottron's papules, the facial erythema with a heliotrope eyelid edema, and the shawl and face rash. Next, when something presents with mixed features, like it has features of SLE, systemic sclerosis, and or polymyositis, then we call it a mixed connective tissue disease, and that's associated with anti-U1 RNP, or ribonucleoprotein. When we talk about rheumatoid arthritis, we think of inflammation that erodes bone and cartilage, like in this diagram. It can even lead to deformities like the swan neck deformity or boutonniere deformity, which is kind of what your fingers look like when you're trying to button up something. Rheumatoid arthritis is associated with rheumatoid factor, which is an IgM antibody against the Fc region of IgG. Anti-CCP, or cyclic citrullonated peptide antibody, is more specific. Now next up is Sjogren's syndrome, which is an autoimmune disorder characterized by exocrine gland destruction, especially of our lacrimal and salivary glands. What happens is that there are lymphocytic infiltrates, like you can see here, that come in and destroy the glands. It's associated with the anti-ribonucleoprotein antibodies SSA and SSB. Now, on this slide, I put a bunch of gastrointestinal related diseases together, and I don't want to just read it all to you, but please make sure you know this list. Now, on this slide, I put the vasculitides together, but if you originally learned these autoantibodies as P-ANCA and C-ANCA, please make sure you know their other names too. Now, I could have put MPO-ANCA on the other slide with the gastrointestinal disorders because of ulcerative colitis, but I think it's nicer to see them all here. Okay, here we have bullous pemphigoid and pemphigus vulgaris, which are really frustrating because they get mixed up a lot. Now remember, pemphigus vulgaris, it's vulgar. It's the potentially fatal one with flaccid intraepidermal bullae, like you could see here. And this is because there are IgG antibodies against desmoglein, which is a part of desmosomes, which connect the keratinocytes in the stratum spinosum, like you can see in this diagram. Now, bullous pemphigoid is less severe, and it's typically seen in older adults with these tense blisters. This is caused by IgG antibodies against hemidesmosomes. Now let's move on to some endocrine disorders. The most common cause of hypothyroidism in iodine-sufficient regions is Hashimoto thyroiditis, and on histology we can see these Hurley cells. It's associated with antimicrosomal, antithyroglobulin, and antithyroid peroxidase antibodies. Then we have Graves' disease, the most common cause of hyperthyroidism. Here in this image we can see the scalloping of the colloid, and it's associated with anti-TSH receptors. Now finally we have some renal disorders. The first is Goodpasture syndrome, which presents with hematuria and hemoptysis and can lead to rapidly progressive or crescentic glomerulonephritis. And you can see the crescent moon shape here in this image on light microscopy. Now, Goodpasture syndrome is due to antibodies against the basement membrane. Membranous nephropathy, as you can see in this image with diffuse capillary and basement membrane thickening, is primary when it's due to autoantibodies to the phospholipase A2 receptor. It can also be secondary to drugs like NSAIDs, penicillamine, some infections, SLE, or even some solid tumors. All right, I know that was a lot, but that's all I have for you here. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard. Hi everyone, this is our lecture on immunodeficiencies, which are a very high-yield concept for your boards. So let's get started. Now, the immunodeficiencies are easier to remember if you can recall the roles of the different players in the immune system and can appreciate how an absent or deranged component might clinically manifest. Now, there are numerous ways to organize the immunodeficiencies, and you should pick a way that you find the most useful. But for the purpose of our discussion, we'll divide the immunodeficiencies on the basis of which immune system component is deranged. Now, there are B-cell disorders, T-cell disorders, B and T-cell disorders, and disorders that have to do with phagocyte dysfunction. Let's start off with the immunodeficiencies that are B-cell disorders. The B-cell disorders include X-linked Bruton A-gamma globulinemia, selective IgA deficiency, and common variable immunodeficiency. Now, first up, we have X-linked A-gamma globulinemia, also known as Bruton's A-gamma globulinemia. Now, this has to do with a defect in the BTK gene, which actually stands for Bruton tyrosine kinase. Now, because of this, there is no B-cell maturation. This deficiency is X-linked recessive, so there's an increase in this with boys, since they only have one X chromosome. Now, anyway, what's the big deal with no B-cell maturation? Why is this so important? What do we need our B cells for? Now, our B cells play a huge role in our humoral immunity. They recognize antigens, they produce antibodies, and they maintain our immunologic memory. So, on clinical presentation, you're typically going to read a vignette about a young boy with recurrent bacterial and enteroviral infections after the age of 6 months. Now, why 6 months? Well, this is when we start losing our maternal IgG protection. What are we going to find with labs or on further investigation? Well, we're going to see absent B cells in the peripheral blood. And since our B cells differentiate into plasma cells to secrete the specific immunoglobulins, we're also going to see decreased immunoglobulins of all classes. So, if we have B cells, where do they hang out and get stored? You're right if you're thinking of the secondary immune system organs like the lymph nodes and the tonsils. But in this case, if we don't have B cells, we're going to have absent or scanty lymph nodes and tonsils. Now, in the lymph node, do you remember which area specifically that B cells localize and proliferate in? Well, they're in the follicles, and the germinal centers are where they are active. But if there aren't any B cells, well, this won't show up. Finally, live vaccines are contraindicated. People with X-linked A-gamma globulinemia, they simply don't have the immune support to handle a live vaccine. Now, let's discuss selective IgA deficiency. The defect here is actually unknown, but it's the most common primary immunodeficiency. Now, the majority of people with selective IgA deficiency are asymptomatic, but what do we need IgA for? You're right if you said it helps to prevent the attachment of bacteria and viruses to mucous membranes. So it makes sense that we can actually see the presentation as airway and GI infections, but also in autoimmune disease, atopy, and very commonly on exams, anaphylaxis to IgA-containing products. Now, this can happen when someone needs a blood transfusion and all of a sudden has an anaphylactic reaction. It could be because the patient is IgA deficient, and since there is IgA in the blood products and it's foreign to the patient, the immune system reacts against it. Now, this can be severely life-threatening. And what will we find? Well, we'll have decreased levels of IgA, but we'll have normal IgG and IgM levels. Now, since IgA is produced in the GI tract and protects against gut infections, especially Giardia, patients with IgA deficiency will have increased susceptibility to giardiasis. Now, here are some images of the trophozoite and cystic form of Giardia. Now, lastly, for the B-cell disorders, we have common variable immunodeficiency. Common variable immunodeficiency is a defect in B-cell differentiation, but the cause is usually unknown. What do B cells differentiate into? Well, they turn into plasma cells and immunoglobulins, so we'll have a normal amount of B cells, but we won't get their differentiated counterparts. Common variable immunodeficiency usually presents after the second year of life, but it could be delayed and show as late as in the third or fourth decade. Patients with common variable immunodeficiency have an increased risk of autoimmune disease, bronchiectasis, lymphoma, and sinopulmonary infections. On labs, there will be decreased plasma cells and immunoglobulins. All right, let's turn our attention now to the immune deficiencies involving T cells. They are thymic aplasia, IL-12 receptor deficiency, autosomal dominant hyper-IgE syndrome, also known as Job syndrome, and chronic mucocutaneous candidiasis. First, let's start with thymic aplasia. Well, what does aplasia mean? I'm sure you know hyperplasia, metaplasia, and dysplasia, but what is aplasia? The prefix a usually means absence of, and in all those examples, plasia means proliferation and growth of cells. But in this case, we don't have the proliferation and growth of thymic cells, so we don't have a thymus. The defect here is a microdeletion in chromosome 22, which leads to failure to develop our third and fourth pharyngeal pouches. So we have no thymus or parathyroids. There are some syndromes associated with this. Can you name one or two? You're right if you're thinking of DeGeorge syndrome, where there will be thymic, parathyroid, and cardiac defects. There is also velocardiofacial syndrome, with defects of the palate, the face, and the heart. Now, thymic aplasia presents as catch-22. The C stands for cardiac defects, and this can include conotruncal abnormalities like tetralogy of Fallot or truncus arteriosus. The A stands for abnormal facies. The T stands for thymic hypoplasia, and thus a T cell deficiency, since the thymus is where T cells mature. The C stands for cleft palate, which you can see a diagram of here. Now, finally, the H stands for hypocalcemia, and this is because of our parathyroid aplasia, and this can manifest as tetany. On labs, we'll see decreases in T cells, parathyroid hormone, and calcium. We'll also see no thymic shadow on chest x-ray. In this image, we see arrows pointing to a little sail sign, which is a normal neonatal visual of a thymus. Next, we have IL-12 receptor deficiency. You've heard of IL-12 before, don't you remember this? Over on the right-hand side, you can see that IL-12 helps induce the differentiation of our helper T cells to Th1 cells. So, our defect here will be a decreased Th1 response, and this is an autosomal recessive disorder. So what will we find? Do you remember what comes from Th1 cells? They produce interferon gamma, so it makes sense that we'll find decreased interferon gamma. Now, there's a pattern of chronic inflammation that depends on Th1 cells and interferon gamma. Can you remember what it is? It activates macrophages to form epithelioid macrophages and giant cells to wall something off. You're right if you're thinking of a granuloma. So on presentation for IL-12 receptor deficiency, a patient may actually have frequent or disseminated mycobacterial and fungal infections, and this can also present after the administration of the BCG vaccines. Next, we have autosomal dominant hyper-IgE syndrome, also known as Job syndrome. This is a deficiency of Th17 cells due to mutation in STAT3. STAT stands for signal transducer and activator of transcription. When we don't have STAT3 functioning right, then we block the maturation of our T cells, especially our Th17 ones. Now, Th17 is one of our T cell subsets, and its function is to have immunity against extracellular microbes by inducing neutrophilic inflammation. So when we have a deficiency, we'll have impaired recruitment of neutrophils. Now, someone with hyper-IgE syndrome can present with abscesses, retained baby teeth, coarse facies, dermatologic problems, increased IgE, and bone fractures. The mnemonic to help you remember this is to learn the ABCDEFs to get a job. On labs, we'll find increased IgE and increased eosinophils. Next, we have chronic mucocutaneous candidiasis. It's actually a group of immune system defects with T-cell dysfunction and impaired cell-mediated immunity against Candida. Now, the classic form of this disease is caused by defects in AIR, or the autoimmune regulatory gene. This disease presents with non-invasive Candida albicans infections of the skin and mucous membranes, and on labs we'll see not only absent T-cell proliferation, but also absent skin reactions to the Candida antigens. Now, here in these images, we can see the budding yeasts and the germ tubes of Candida albicans, and also a clinical image of oral thrush. Now let's move on to combined B and T cell disorders. They are severe combined immunodeficiency, ataxia telangiectasia, hyper-IgM syndrome, and Wiskott-Aldrich syndrome. Now, severe combined immunodeficiency comes in several types, including a more common X-linked recessive version, which has to do with the IL-2 receptor, and the autosomal recessive version, which is caused by adenosine deaminase deficiency. Now, adenosine deaminase deficiency should sound familiar to you. It's part of our purine salvage pathway, and I've included an image of that on the next slide for you to review afterwards. So this presentation is going to be pretty severe. It's a combined immunodeficiency of both B and T cells. So patients present with failure to thrive, chronic diarrhea, and thrush. They have recurrent infections of all types: viral, bacterial, fungal, and protozoal. As treatment, we have to avoid live vaccines, and we have to give prophylaxis and IVIG, IV immunoglobulins. Where do both our B cells and T cells come from? You're right if you said the bone marrow. So a bone marrow transplant is curative. We'll find decreased T-cell receptor excision circles, an absent thymic shadow on chest x-ray, no germinal centers on lymph node biopsy, and no T-cells on flow cytometry. These patients are severely deficient. Now, here is that purine salvage pathway I know you all couldn't wait for. All right. Next, we have ataxia telangiectasia, which is autosomal recessive and caused by defects in the ATM gene, which stands for ataxia telangiectasia mutated. Another biochemistry throwback for you: without this gene, we'll have failure to detect damaged DNA, and then we can't stop the cell cycle from progressing, so mutations accumulate. On presentation, there's a triad for this, which of course includes ataxia and telangiectasia, or spider angiomas. There's also IgA deficiency. So remember what we've discussed with IgA deficiency, and if you see those presenting signs and symptoms with ataxia and spider angiomas, then you want to consider ataxia telangiectasia. Now, here's an image of telangiectasias for you, and other findings we'll have are increased AFP, decreased IgA, IgG, and IgE, lymphopenia, cerebellar atrophy, and an increased risk of lymphoma and leukemia. Now let's talk about hyper-IgM syndrome. This is an X-linked recessive disorder due to defective CD40 ligand on T helper cells, and it leads to a class switching defect. If we can't class switch, what won't we have? We won't have a lot of IgG, IgA, or IgE. We don't really need those, right? Well, understandably, patients with hyper-IgM syndrome will present with severe pyogenic infections early in life, and they'll get opportunistic infections with pneumocystis, cryptosporidium, and CMV. So on findings, we'll see normal or increased IgM, severely decreased IgG, IgA, and IgE, and will have failure to make germinal centers. Next, there's Wiskott-Aldrich syndrome. There's a mutation in the WASH gene, and we can't present antigens well because the leukocytes and platelets can't reorganize the actin cytoskeleton and move around like they want to. There's a helpful mnemonic for the presentation, and it's water. So the W and A stand for Wiskott-Aldrich, the T stands for thrombocytopenia, the E stands for eczema, and the R stands for recurrent pyogenic infections. Wiskott-Aldrich also increases the risk of autoimmune disease and malignancy. Now, because of the thrombocytopenia, we'll see few and small platelets, and we'll also see decreased to normal IgG and IgM with increased IgE and IgA. Finally, we bring our discussion to the immune deficiency states that arise from phagocyte dysfunction, which include leukocyte adhesion deficiency type 1, Chiari-Higashi syndrome, and chronic granulomatous disease. First, we have leukocyte adhesion deficiency type 1, which is autosomal recessive. It occurs when there's a defect in LFA1 integrin on phagocytes, so this impairs migration and chemotaxis. It presents with recurrent skin and mucosal bacterial infections, but absent pus, with impaired wound healing and delayed separation of the umbilical cord. This is the typical buzz phrase for leukocyte adhesion deficiency. Now, what will we find? We'll see increased neutrophils in the blood and absence of the neutrophils at the infection sites. Now, this should make sense because LFA1 is right smack in the middle of this diagram. And if these neutrophils can't migrate and get to the site of infections, they're just going to be hanging out in the blood. And they're not going to get to the sites of infection if the integrin doesn't help them out. Okay, next we have Chiari-Higashi syndrome. This one is pretty unique because it's a defect in the lysosomal trafficking regulator gene, and it has to do with microtubular dysfunction when phagosomes and lysosomes fuse. It's autosomal recessive, and its presentation can be abbreviated with the mnemonic PLANE, which stands for progressive neurodegeneration, lymphohistiocytosis, albinism, recurrent pyogenic infections, and peripheral neuropathy. Here's a picture of albinism, and in this image, we can see our findings. There are giant granules in the granulocytes and platelets. There's also pancytopenia and mild defects in the coagulation system. And finally, we have chronic granulomatous disease. The most common form is an X-linked defect in NADPH oxidase, which should remind you of our respiratory burst. We'll have a decrease in reactive oxygen species and decreased respiratory burst in neutrophils. Because of this, there will be an increased susceptibility to catalase-positive organisms. Can you name a few? You're right if you mentioned Staphylococcus, E. coli, and Candida, but make sure you go back to your microbiology to look at the rest of the list. This one has a few weird name tests, and those include the dihydroorotamine flow cytometry test, which will show decreased green fluorescence, and the NBT dye test, or nitro blue tetrazolium test, which would fail to turn blue. Well, that was a lot, and thankfully that's all I have for you here. So please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard. Hi everyone, this is our lecture on infections in immunodeficiency. So let's get started. Now, when we say deficient, we're usually thinking that there's a component of our immune system missing, whether it's our B cells, T cells, granulocytes, or even a part of complement. And when we say immunocompromised, it means you're in a state where you don't have the best ability to fight an infection. Maybe the patient's a neonate and literally hasn't been exposed to anything before. Maybe the patient is on steroids or chemotherapy. When it comes down to it, an easy way to remember the infections you'll get in immunodeficiency is that B cell deficiencies tend to produce recurrent bacterial infections. B for B cell and bacterial. Our B cells are humoral immunity, recognizing antigens, antibodies, and maintaining immunologic memory. Now, in this image, we can see the important roles our antibodies play in our encounters with foreign bacteria. What about our T cells? They run our cell-mediated immunity. T cell deficiencies produce more fungal and viral infections. Now, keep those general rules in mind as we go through the next couple of slides. Now, let's talk about infections due to bacteria and immunodeficiency. So first, what happens when we encounter a bacteria but we're deficient in T cells? Well, without our T cells, a minor infection can turn into sepsis. What if we're deficient in B cells? Well, we'd especially have trouble with our encapsulated bacteria, and our mnemonic for those is "Please shine my skis." And here is the list of those microbes for you. Now, in particular, I wanted to highlight this image. Do you know what this is? It's a rapidly progressive, necrotic, cutaneous lesion called thymogangrenosum. It's caused by Pseudomonas bacteria, and this is typically seen in immunocompromised patients. Now, here in this image, we can see some very mucoid colonies due to abundant polysaccharide capsules. It can result in current jelly sputum. Now, you're right if you're saying this is Klebsiella. Now, what if we encounter a bacteria and we're deficient in granulocytes? Well, we can use the mnemonic "Some bacteria produce no serous granules" to help us remember Staphylococcus, Burkholderia cepacia, Pseudomonas aeruginosa, Nocardia, and Serratia. Now here in this image, we can see the weakly acid-fast staining of Nocardia with its long branching filaments. This can cause pulmonary infections in immunocompromised individuals. It mimics tuberculosis, but the PPD will come out negative. Anyway, what about if we're deficient in complement? With early complement deficiencies, we'll see infections due to encapsulated bacteria. With the late complement deficiencies, especially C5 through C9, which make up the membrane attack complex, we'll have more infections due to Neisseria. Now that we've talked about some bacteria, let's talk about common viral infections in immunodeficiency. When we have decreased T cells, we are more susceptible to CMV, EBV, JC virus, VZV, and chronic infection with respiratory and GI viruses. Here in this image, we see the owl eye intranuclear inclusions that are characteristic of CMV. Now, this typically presents as mononucleosis in immunocompetent patients, but it can present as infection in immunocompromised patients, especially pneumonia in transplant patients. Now, in this next image, we see some atypical lymphocytes on peripheral blood smear, which we can see with EBV. And can you tell me what this image is? It's shingles due to varicella zoster, but it can also present as chickenpox, encephalitis, and pneumonia. Now, if we have decreased B cells, we are susceptible to enteroviral encephalitis and poliovirus. Thus, the live vaccine is contraindicated. Now, finally, let's talk about infections due to fungi and parasites in immunodeficiency. If a patient is deficient in T cells, the patient is susceptible to local Candida infections, like the oral thrush seen here, PCP and Cryptococcus, which you can see here with the clear halo with India ink. This can cause cryptococcosis, cryptococcal meningitis, and cryptococcal encephalitis, primarily in immunocompromised people. Now, if a patient is deficient in B cells, he or she will have less production of immunoglobulins, and without IgA in particular, they'll be susceptible to giardiasis. Now, if a patient is deficient in granulocytes, he or she will be susceptible to systemic candidiasis and aspergillus, which is shown here with its acute angle branching and can cause invasive aspergillosis in immunocompromised patients. Now, deficiency of granulocytes can also lead to infections with the mucor species shown here, with its irregular, broad, non-septate branching, and it causes mucormycosis through spore inhalation. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard. Hi everyone, this is our lecture on transplant rejection. So let's get started. There are 4 forms of transplant rejection, all of which are immune-mediated. Now, this explains the essential role of immunosuppressants in protecting transplanted organs from the recipient's immune defense. With these, you'll want to pay special attention to the time frame during which each occurs, as well as their features. So the 4 types of rejection are hyperacute, acute, chronic, and graft versus host disease. Now, as for the onset after transplant, hyperacute rejection occurs rapidly, within minutes. Acute rejection is still relatively quick, but the typical onset is weeks to months from the date of transplant. Chronic rejection occurs months to years later. And graft versus host disease, it varies in onset. So the first type of rejection we're going to discuss is hyperacute transplant rejection. Again, the onset is within minutes. When we talk about the pathogenesis, this is a type 2 hypersensitivity reaction, which, if this image helps you recall, antibodies bind to the cell surface antigens on the abnormal or foreign cell, leading to cellular destruction, inflammation, and cellular dysfunction. Now, in this case, there are pre-existing antibodies in the person receiving the transplant, and those antibodies are reacting to the antigens from the donor. This also activates complement. What we're going to see is widespread thrombosis of graft vessels, ischemia and necrosis, and the graft must be removed. Now here in this image, we can see a renal transplant, and there are arrows pointing within the glomerulus. On histology, you should see this vascular congestion, fibrin and platelet thrombi, neutrophilic infiltrate, and fibrinoid necrosis. Now, let's talk about acute transplant rejection. As I said previously, acute transplant rejection occurs weeks to months after the transplant. In terms of pathogenesis, there are 2 components, a cellular and a humoral component. In the cellular component, we have CD8 and or CD4 T cells that are activated against the donor MHCs. This is a type 4 hypersensitivity reaction. The humoral response is very similar to the hyperacute process, but the antibodies develop after the transplant. They are the recipient's antibodies, and they made them against the graft or the donor. The graft came in, and the body said, there's something I don't like about you, and it made antibodies against it. So in this image, it's a good visual of the features of acute transplant rejection, which include vasculitis of graft vessels with dense interstitial lymphocytic cellular infiltrate, which is what the arrows are pointing to. What's happening is a rejection vasculitis, in which the antibodies start attacking the endothelial cells, and this can lead to inflammation of the endothelium, or endothelialitis. We can prevent or reverse acute transplant rejection with immunosuppressants. Now, chronic transplant rejection can occur months to years after the transplant. What happens is that when the transplant or donor part came in, the donor had peptides. And so the recipient who got the transplant saw those peptides and responded by getting its antigen-presenting cells ready to do their job, and present them to the T cells. Now, this involves both cellular and humoral components, and thus this counts as both a type 2 and a type 4 hypersensitivity. So, onwards with my peptide story. The antigen-presenting cells showed the T cells, and the T cells reacted, and they started secreting cytokines. So these cytokines cause the proliferation of vascular smooth muscle, parenchymal atrophy, and interstitial fibrosis. Like here in this image, we can see this smooth muscle proliferation, and this reaction is dominated by arteriosclerosis, as indicated by the arrow. Now, if we talk about other organs where this can happen, just thinking about the other things that can slowly lose its lumen. We can have bronchiolitis obliterans in the lung, accelerated atherosclerosis in the heart, chronic graft nephropathy in the kidney, and vanishing bile duct syndrome in the liver. Now lastly, let's talk about graft versus host disease. The onset varies. What happens is that we get T cells that came in with the graft, and these T cells start proliferating in the host or the recipient who is immunocompromised. And those T cells from the donation or transplant, they start rejecting the host cells with their foreign proteins. So the graft is beating up the host, and it causes severe organ dysfunction. This is a type 4 hypersensitivity reaction. What will we see? Patients can present with a maculopapular rash, jaundice, diarrhea, and hepatosplenomegaly. This typically occurs in bone marrow and liver transplants. Why? Because they're rich in lymphocytes. Well, what could this be good for? Well, what if we want our body to get attacked? Why would we want that? Well, maybe there's something bad in it. So this is potentially beneficial when we're trying to do a bone marrow transplant for leukemia. It kills all the bad stuff. To prevent this, we can irradiate our blood products prior to transfusion, especially for immunocompromised patients. So let's test ourselves with a question. Pause the video if you want to read it and attempt it on your own, and then hit play again. A 55-year-old man with diabetes develops end-stage renal disease and requires a kidney transplant. After the transplant surgery, the patient meets with his nephrologist. His urinary frequency and volume are unchanged. Laboratory results show increased serum creatinine and BUN. On renal biopsy, there are dense infiltrates of CD8 positive cells and significant inflammation of the graft vessels. How long after the transplant did the patient most likely present with this new condition? So first, we need to figure out what kind of rejection this is. He has dense infiltrates of CD8 positive cells and inflammation of the vessels. So vasculitis. If you recall, the one we talked about with vasculitis of graft vessels, and the one where I showed you a picture of dense interstitial lymphocytic cellular infiltrate, is an acute transplant rejection. Now, the typical onset for acute transplant rejection is what? It's weeks to months. Now, D and E, 3 days to 6 hours, those are way too short. A is 18 months, which is already over a year, and C is 2 years. So A and C are too long. So the correct answer is B, 2 weeks. Make sure you know the timing and the features and pathogenesis for these transplant rejections. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard. Hi everyone, this is our lecture on immunosuppressants, so let's get started. Now, in this age in which organ transplantation and targeted therapies have become so commonplace, it's pretty important to know at least a little bit about immunosuppressants. So, although not all physicians will end up prescribing immunosuppressants in the future, we will still get tested on whether or not we understand how these drugs work. And ultimately, it's our job to know exactly how these drugs work and why they might benefit a patient. With that information, we can better educate patients and help them make more informed decisions. Now, immunosuppressants are agents that block lymphocyte activation and proliferation. They help to reduce acute transplant rejection by suppressing cellular immunity by being used as prophylaxis. To achieve greater efficacy with less toxicity, we even sometimes combine them. However, if we use them chronically, the suppression of the immune system can lead to increased risk of infection and malignancy. So in order to better visualize how each of these drugs work, we're going to use this diagram to better understand what each of these drugs ultimately do. So this diagram represents the different ways that our immune or inflammatory response can be activated. Over here, we have the IL-2 receptor, which we know is necessary for NK and T cell activation. We have the T cell receptor over here, and we have some key players in purine synthesis. So let's go through this. So cyclosporin is a classic immunosuppressant that blocks the differentiation and activation of T cells by inhibiting calcineurin, a molecule which is necessary to produce IL-2 and its receptor. More specifically, cyclosporin exerts its action through the binding of cyclophilins. Now let's review how T cells are normally stimulated and then see how cyclosporin acts to inhibit this. What happens normally? Normally, when a receptor is stimulated, cyclophilins, along with calcineurin, stimulate NF-AT and ultimately further production of inflammatory cytokines. However, cyclosporin inhibits this cascade and ultimately the downstream synthesis of IL-2, thus further T cell stimulation by binding to and inhibiting cyclophilins. Now, tacrolimus is another immunosuppressant medication that acts to inhibit T cells. Tacrolimus acts very similarly to cyclosporin. However, it mediates its effects using second messenger proteins called FK binding proteins instead of cyclophilins. Now, cyclosporin has been indicated for use in psoriasis and rheumatoid arthritis. Both cyclosporin and tacrolimus are highly nephrotoxic, especially in higher doses or in patients with decreased renal function. You can see the other toxicities for the calcineurin inhibitors listed here. Now, sirolimus also inhibits T cell proliferation in response to IL-2, but this time by binding to mTOR. It is classically used in combination with other immunosuppressant agents such as cyclosporin and the corticosteroids. Daclizumab and basiliximab exert their effects through antibody-mediated binding to an IL-2 receptor that ultimately inhibits the mTOR pathway of immune cell activation and proliferation. Basiliximab is a monoclonal antibody that targets the IL-2 receptor directly on the surface of the cell, whereas sirolimus disrupts the downstream cascade from where the receptor was stimulated. Now, sirolimus and basiliximab are both used specifically for kidney transplant rejection prophylaxis. You can remember this with the mnemonic Sir Basil's kidney transplant, and that the kidneys survive. With sirolimus, watch out for pancytopenia, insulin resistance, and hyperlipidemia. With basiliximab, watch out for edema, hypertension, and tremor. Now, azathioprine exerts its effects through toxicity to proliferating lymphocytes. This medication is an anti-metabolite precursor of 6-mercaptopurine that interferes with the synthesis of nucleic acids by locking into and disrupting DNA replication as shown. Now, mycophenolate mofetil exerts its effect directly and competitively by inhibiting IMP dehydrogenase, thus preventing purine synthesis of B and T cells. Now, this drug has limited use because there are many other better players out there now, but it does still play a role in the treatment of lupus nephritis. Now, immune cells are normally highly proliferative. However, without DNA replication, their proliferation is halted and thus the immune system gets compromised. So azathioprine actually has some utility in some autoimmune disorders, like rheumatoid arthritis and Crohn's disease. As with most of the other immunosuppressant medications, use of azathioprine is limited by its toxicity, specifically bone marrow suppression. Can you think of what the most likely clinical manifestation of marrow suppression would be? It'd probably be anemia. For some farm bonus points, who can tell me what drug to avoid if a patient is on azathioprine or 6-mercaptopurine? Right, your gout medications like allopurinol. Anyone remember the mechanism behind that? Boom, because 6-mercaptopurine is degraded by the enzyme xanthine oxidase, which is what allopurinol blocks to treat your gout. So if you have a patient on azathioprine and their xanthine oxidase is inhibited, then they're going to experience dangerous elevations in circulating drug levels. Not good. Remembering something like that saves a patient's life. Now, steroids are incredibly important immunosuppressants to know and are very, very commonly used in practice. Their various uses, actions, and side effects will be discussed extensively throughout this text. However, for now, we'll just deal with the root of how they work. They basically turn off the immunologic on switch. What is that? Well, it's NF-kappa beta. Thus, proliferation and synthesis of stimulatory cytokines is disrupted. So, what's important to take away from the immunological angle of steroids is that they shut off the ability for the body to make the DNA necessary to mount an inflammatory response and thus prevent or reduce inflammation. Now we know that there are a variety of uses for steroids as well as a variety of adverse reactions to using them long term. So the general point is that if you can avoid long-term use, be sure to do so. So here is the entire image again with all of the different mechanisms from your text. Take a minute to absorb where each drug works and how they all have a similar goal in immunosuppression. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and I'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.
There are many different targets in immunosuppressive therapy, which are all discussed in a separate lecture. But in this lecture, we're just going to point out all the different targets that we have to work with. We have the IL-2 receptor, calcineurin, mTOR, IMP dehydrogenase, PRPP aminotransferase, and NF-kappa beta. Please refer to the immunosuppressant drugs lecture for an in-depth look at how these specific sites are targeted for therapy.
Hi everyone, this is our lecture on recombinant cytokines and clinical uses. So let's get started. So remember that cells communicate through cytokines. They include our interleukins, interferons, chemokines. They get produced by different cells in the body and help our immune system. So it makes sense that some recombinant cytokines have been created and have clinical uses. So first, let's talk about a few that have been developed which stimulate the bone marrow. Now, the first one listed here is erythropoietin. Erythropoietin is commonly used to stimulate erythrocyte production, and we definitely need more red blood cells in anemias. Its use is particularly common in chronic renal failure patients. Why is it important for chronic renal failure patients? Because the kidney is where EPO is normally synthesized. Filgrastim and sargramostim are both colony-stimulating factors used in leukopenia, especially for the recovery of bone marrow after suppression from disease states. Romiplastim is a thrombopoietin analog, and L-trombobag is a thrombopoietin receptor agonist. They are platelet stimulators, and thus they're useful in autoimmune thrombocytopenia. Now on this slide, we have some recombinant cytokines that are useful as immunotherapy. Aldesleukin, or IL-2, has been shown to be effective in metastatic melanoma by stimulating cytotoxic T cells to apoptose malignant cells. Although mortality for this disease, when not amenable to local control, still remains devastatingly high. It has also been used for renal cell carcinoma. Now, onto the interferons. Recall that interferons increase the MHC expression of virally infected or malignant cells, and thus make it easier for immune cells to target and destroy them. You could think of them as miniature highlighters for immune cells to better identify. So alpha interferon is most commonly used in chronic hepatitis C and B infection, as well as renal cell carcinoma, while beta interferon is the classic cytokine that has demonstrated some utility in multiple sclerosis. Gamma interferon is used for chronic granulomatous disease. So this is a great way for exam writers to integrate your basic immunology with pathology and pharmacology, so make sure you're familiar with them. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.